Do you struggle to remember the difference between COPD and asthma? You're not alone. Many nursing students confuse these two respiratory conditions because both can cause wheezing, shortness of breath, and coughing. But here's the good news. By the end of this video, you'll clearly understand the differences between COPD and asthma, the key symptoms, treatment, nursing priorities, and NCLEX concepts you'll need to know. Let's make this simple. Hi everyone, and welcome to Clever Concepts Academy, where we simplify difficult nursing concepts to help you succeed in nursing school and prepare for the NCLEX. If that's helpful to you, be sure to subscribe and let's dive in. Let's start with the simplest explanation possible. Both COPD and asthma affect airflow in the lungs. The major difference is this. In asthma, airway narrowing is usually reversible. But in COPD, airway narrowing is progressive and largely irreversible. That one distinction alone can help answer NCLEX questions. Think of it this way. Asthma is like a door that occasionally gets stuck, but can still open again. COPD is like a door whose hinges have become permanently damaged over time. So what is asthma? Asthma is a chronic inflammatory disease of the airways. In response to triggers, the airways become inflamed, swollen, narrowed, and filled with mucus. Common asthma triggers include pollen, dust, pet dander, exercise, cold air, respiratory infections, and smoke. Symptoms often occur in episodes. Clients may be completely symptom-free between attacks. Common symptoms include wheezing, coughing, chest tightness, and shortness of breath. One hallmark of asthma is that symptoms often improve with bronchodilators. Here's an NCLEX pearl. Asthma is generally considered reversible. If you remember only one thing about asthma, remember that. What is COPD? COPD stands for chronic obstructive pulmonary disease. COPD is actually an umbrella term that commonly includes chronic bronchitis and emphysema. Unlike asthma, COPD usually develops over many years. The most common cause is cigarette smoking. In COPD, airways become chronically inflamed, mucus production increases, lung elasticity decreases, and air becomes trapped inside the lungs. Patients often experience a chronic cough, excessive mucus production, progressive shortness of breath, and decreased exercise tolerance. Unlike asthma, symptoms are often present daily. Let's look at the difference between chronic bronchitis versus emphysema. When you look at chronic bronchitis, think mucus problem. Patients have a chronic productive cough, excessive mucus, and airway inflammation. A classic description for clients with chronic bronchitis is the term blue bloater due to hypoxia, which is a lack of sufficient oxygen in tissues. There is also fluid retention in the lower extremities, specifically the feet, ankles, and legs. In emphysema, think air trapping problem. The lungs lose elasticity and become damaged. Clients struggle to exhale effectively. A classic description for clients with emphysema is the term pink puffer, because they work very hard to breathe, and while breathing, they manage to maintain a normal or pink tone to their skin. Let's compare the symptoms between asthma and COPD. Asthma often begins younger. It is trigger related. Symptoms come and go. There is a reversible airway narrowing, and wheezing is common. COPD usually occurs in older adults. Smoking history is common. Sometimes symptoms gradually worsen. There is irreversible lung damage, and a chronic cough is common. Let's review oxygen considerations. Here's an important nursing concept. Many COPD patients live with chronically elevated carbon dioxide levels. While oxygen should absolutely be given when needed, COPD patients require careful monitoring because excessive oxygen can worsen carbon dioxide retention in some patients. The key point is monitor oxygenation carefully and follow prescribed oxygen targets. Because if you give too much oxygen to a client with COPD, the client will lose their drive to breathe. Medications that we use for the treatment of asthma include rescue medications such as albuterol, which is a bronchodilator and also known as a rescue inhaler. It will open up the airways in the lungs, improve breathing, decrease chest tightness, coughing, and wheezing. Long-term control of asthma is managed by the use of inhaled corticosteroids, which decrease inflammation in the lungs. Leukotriene inhibitors are also used to decrease inflammatory substances, which are released when a client encounters a trigger that stimulates an asthmatic attack. These medications are taken daily to decrease inflammation, airway narrowing, and mucus production. And COPD medications also include bronchodilators such as albuterol, anticholinergics such as ipratropium, which are used to keep the muscles relaxed and the airways open. Albuterol and ipratropium are often used together and inhaled by the client to decrease constriction of the bronchi, which of course is the pathway for gas exchange, and to relax the muscles surrounding the airway, making it easier for the client to breathe. Inhaled corticosteroids are used to decrease inflammation, and oxygen therapy is given if needed, but monitored very carefully. Here's an NCLEX tip. Students often confuse rescue and maintenance medications. Remember, albuterol is commonly the rescue inhaler. What are the nursing priorities? For both conditions, assess respiratory rate, oxygen saturation, breath sounds, and monitor work of breathing, which is how hard your body has to work to pump air in and out of your lungs. Teach clients how to use their inhaler for medication administration. Provide resources for smoking cessation. Encourage clients to avoid triggers that will stimulate an attack, and encourage them to take their medication as prescribed to decrease the frequency of attacks. For COPD specifically, monitor for worsening hypoxia, monitor for respiratory infections, and increasing shortness of breath. Here's a quick case study. A 68-year-old client with a 40-year smoking history reports a chronic cough, increased mucus, and worsening shortness of breath. Which diagnosis is most likely? The answer is COPD. Why? Because of the smoking history, progressive symptoms, and a chronic productive cough. Here's the final review. Let's summarize. Asthma, usually reversible, trigger-based, and there is episodic symptoms. COPD, progressive, usually smoking-related, and largely irreversible. Remember, asthma equals reversible. COPD equals progressive and irreversible. If this video helps simplify COPD and asthma for you, please subscribe and share it with another nursing student. Thank you for watching, and I'll see you in the next video.